university exams, but exams like NEET, PG, and FMG. I hope you guys must be updated, or your seniors might have been updated that this NEET PG, which was actually postponed, is now on 11th of August, right? It is now on 11th of August. It was supposedly to be happening on 23rd of June. Then one day back, it was got postponed, and now the dates have come yesterday only, and it is now 11th of August. Fine. So these are the topics that we are going to cover today. Day before yesterday, we talked of the basic concepts of peritoneum. If you guys remember, if not, then I do ask you to go and have a look at that previous session as well. So peritoneum is what we discussed, and today we are going to extend the discussion. And these are the important subtopics of peritoneum and the peritoneal spaces. The mesenteries is what we are going to discuss today. Here we can look at all the core features of Auricle. So live classes, recorded notes, and MCQs, what you normally get over here. And these are the basic plans. The basic plan of 3 months of 15K, and standard plan of 6 months of 30K, and mentorship plan of 12 months of 50K, right? So let's jump on to our topic now. And here's the topic now. Okay. So let's start to have a look at it. Fine. So yeah, this is the topic which we're going to discuss today. With previous session, the last topic that we discussed was about this less momentum over here, right? Let me just show you. Yeah, so less momentum is what we discussed the last topic in the previous session. We are going to extend our discussion from there, and now we are going to discuss this part over here. Just a second. Yeah. So mesentery. As we discussed that all these are nothing but these are double layered fold. These are double layered peritoneal folds. These are double layered peritoneal folds. And what do they carry? All these peritoneal folds, which are double layered, they will be carrying mainly nerves, vessels, and lymphatics. Just remember these three things, which are your nerves, which are the vessels, lymphatics, the three basic things. And obviously, as you learned in the previous session, the functions of the peritoneum or the mesentery, they also are a storage of the fat over here. So what's the mesentery? Mesentery is simply the double layered fold of peritoneum, but for what? For the small intestine, right? So it is basically for the small intestine. Let me highlight over here. Small intestine basically will have what? Basically, it will have duodenum, jejunum, and ileum, right? So three things are there in the small intestine. It has a duodenum, it has a jejunum, and it has a ileum. Remember, there is ILEUM, right? It is not ILIUM. ILIUM is ileum, that is a bone, right? It is a part of the hip bone. When you talk about intestine, it is ILEUM. So small intestine has these three parts: duodenum, okay, jejunum, and ileum. In that, we should be knowing that duodenum is retroperitoneal, while these two are intraperitoneal, and therefore the mesentery, which is written over here, is actually hanging the jejunum and the ileum. That we should need to understand now. Here is a look at the mesentery, the image of mesentery. Now remember that the jejunum and ileum are quite long. Okay, they are quite long. They are many foot. So it's quite a long tube over there, small intestine. So therefore, it will have multiple folds. The mesentery over here. You can see this mesentery over here, and this is all the small intestine that is shown over here. The upper left side on this area, this is basically the area of the jejunum, and the lower right side, this is basically the area of the ileum. Now, what are the difference of jejunum and ileum? That we learn in detail as we go forward. But understand, the upper left part of the small intestine is jejunum, the lower right part of the small intestine, that is ileum, and that continues into the cecum over here. So this is the cecum over here. Okay. So this over here is the mesentery, which as you can see is the holding all of the small intestine over here. Now let us see over here. So what are the borders of it? So see that the small intestine is quite a long structure in itself, but the mesentery is how much? The mesentery root is only 15 centimeter long. So imagine that from the root from where the mesentery is starting, it's only 15 centimeter in length. Okay, and then it will spread out to cover to enclose the entire jejunum and the entire ileum. So it's going to be a very long. Okay, so the apex part, or you can say the terminal part of the mesentery is quite long. It is going to cover up the entire jejunum and ileum. But the root is only 15 centimeter long. That is important. So let us see the borders over here. So attached border or the root of mesentery as written is 15 centimeter long, directed obliquely, okay, and downwards and to the right. So this is the direction. It is oblique, downwards and to the right. That is the direction. It extends from where to where? It extends from DJ flexure. So where the duodenum ends and jejunum starts. On left side of the vertebrae L2 to the upper right of right sacroiliac joint. So basically, in a simple understanding, you should know that the root of mesentery, it starts from the DJ flexure to the right sacroiliac joint, right SI joint. As simple as that. You remember this much, it's fine. So it is from the DJ flexure to the right SI joint. Crosses the following structures. Now imagine this root will be present where in the body? If I give you two options, the root is present more anteriorly or more posteriorly. If you have seen the previous session, we discussed that the root is attached to the posterior abdominal wall, right? Posterior side. Therefore, this root is present more posteriorly. Okay, but the question normally comes that does the root cross any structure? Yes, the root is going to cross some structures. So the root, though present posteriorly, is going to cross some other structures as well. Those structures will be lying behind the root of mesentery. What are those structures? All these structures obviously will be behind the root. So they will be sort of retroperitoneal only. Apply the common sense also. So what is the third part of duodenum? Abdominal aorta, IVC, ureter, and psoas major. All these structures, which the names are mentioned over here, they are present more posteriorly. Now let me try to make a diagram over here and make some sense out of it. See, this is, imagine the first part of duodenum, then the second part, then the third part, and then you have this fourth part. So let me write the number 1, 2, 3, and 4. This black color is the mesentery root, which is going from DJ flexure to right sacroiliac joint. Can you see that it is crossing the third part of duodenum anteriorly? Yes, because duodenum itself is retroperitoneal. Okay. Then aorta and IVC, obviously, why? Because they are the most posterior structures. Well, these aorta IVC are going to give out vessels, which is going through the mesentery. Then ureter psoas major. See, ureter psoas major is present, you can say, it is a muscle of the posterior abdominal wall. The kidney sits over the psoas major and the quadratus lumborum. Okay, and from the kidney comes out what is the ureter? Why? Yeah, right ureter, because see, the obliquity of the root of mesentery is downwards and to the right side. If it was straight down or going to the left side, then it would have crossed the left ureter. As the obliquity is towards the right side, therefore it is crossing the right ureter. And it is going from left to right, so it will cross both these major vessels, aorta, IVC. And as I showed you in the beginning, that it is crossing the third part of duodenum, not the first or second part. Right? And finally, it is also crossing the psoas major, because everything is seated over the psoas major. So what I'm trying to make over here is make you understand why these structures, okay, have some basic idea of why it is crossing this, some basic concept of it. That's it. Okay, so these are the structures crossed by the root of mesentery. Okay, here is the root of mesentery shown. Let me show you over here. This is the duodenojejunal flexure over here, right? Behind you can see the aorta IVC. Okay, this is the aorta IVC over here, and this is DJ flexure. And you can see this is the whole root of mesentery going down. And what it is crossing? It is crossing what? It is crossing the third part of duodenum. It is crossing the aortas, the IVC over here. Okay, and here you can see the right ureter as well. And this whole muscle is psoas major. This whole muscle over is the right side psoas major. Now, the root of mesentery, can you see this dotted structure? This dotted structure over here. This is the root of mesentery. Now, what will be there inside running through the mesentery? Mesentery, just imagine, see. Suppose you can look at my hand over here. This is, imagine, the posterior abdominal wall. And this, imagine there's a whole small intestine lying over here. This root of mesentery, 15 centimeter oblique, will go and will spread out and will cover this whole small intestine. So this is a root, it is fixed. This root is fixed, and the small intestine, jejunum, ileum, they are slightly moving during peristalsis. Got the point? This root is fixed over here. Now behind the root, you have the aorta and IVC. Okay. So what is there inside this whole mesentery? Inside this whole mesentery, this is as we discussed, are nerves, vessels, and lymphatics, and obviously some fat. Which vessel will be there? It is supplying jejunum and ileum. Now, jejunum and ileum are a part of foregut, midgut, or hindgut. If you have the basic idea, we've discussed also previous session, jejunum, ileum are a part of the midgut. Which is the artery of midgut? It is superior mesenteric artery, and that is the reason you can see that superior mesenteric artery is written over here. It is lying in the root of mesentery. Then it will give off the jejunal branches, ileal branches, and so some other branches they are going to supply. Just an example of the vessels which will be lying inside the double layered fold of peritoneum known as mesentery. And that would be the content. So the contents of mesentery over here are again depicted. So jejunum and ileal branches of superior mesenteric artery. Why? Because we have this midgut, that is jejunum and ileum. Accompanying veins. So in veins, you have nerves, vessels, and lymphatics, as I told. So don't forget this: nerves, vessels, and lymphatics always. Along with the lymphatics, obviously, you're going to have lymph nodes. Because the lymphatics are draining where? Into the lymph nodes. So you'll have the lymph nodes, and finally you have the fat. So now there's the lymphatics and obviously the fat. With the lymphatics L, you have lymphatics as well as lymph nodes. What's the use of it? If suppose there's an infection or malignancy, it is starting in the gut. So those malignant cells, if they're carried by the lymphatics, those initial lymph nodes will be involved. What are those lymph nodes known as? Depending on the name. Okay, it could be paraileal nodes, intermediate nodes, some any names like that. So these are the contents of mesentery. I hope you got the point of how to write an answer. So remember, in case of mesentery, to start with the root, obviously. From where to where it lies. Root will not move. It is the small intestine that is moving. And then you have to tell about what structures does it cross. And then you tell about a diagram is important over here, guys. And how to draw the diagram, start from the most posterior structure. What is the most posterior structure over here? The aorta IVC. When you're making a diagram, guys, remember to start with the aorta I have drawn like this. Then to the right of it, I'm drawing the IVC. Okay. Then let me draw this duodenum over here. This duodenum, right? Over here. Okay. Then you should know that this is the transpyloric plane. Here you have the hilum of the kidney. Then from here emerges what? From here emerges behind the duodenum, you have this ureter that is going down. You have the ureter that is going down. And behind all of this, we should also make what? You should also make a muscle over here, that is the psoas major, like this. And then finally, you can make out what the root of mesentery. Root of mesentery, you can say, okay, it is going from here to here. The root of mesentery is going, and therefore it is crossing these structures. So some basic diagrams are important, guys. You should try to make and show. And contents, I hope it is clear. Because this is a mesentery. Now, the same, a very small component over here is mesoappendix. What it will be covering, obviously, the name suggests it is covering the appendix over here. It is covering the appendix over here. So let us see. Mesoappendix is a small triangular fold of peritoneum, suspends a vermiform appendix from posterior surface of the lower end of mesentery close to the ileus. See, where is appendix? Appendix is attached to the cecum. So where you have the ileocecal valve, right, where the ileum opens into cecum. Just below that, you have the vermiform appendix, and therefore you will have the mesoappendix over there. Extends up to the tip of appendix, sometimes fail to reach. So it extends up to the tip of appendix. So it will start around the ileocecal junction as written over here, close to ileocecal junction. And then obviously a simple diagram will help you. So try to how to make the diagram, because anatomy, you see, we normally think, if you are not very good in art and drawing in your school time, and once you enter the medical college first year, you are given the gift of anatomy. Then there are a lot of diagrams in anatomy. And your faculties in the college, they ask you, okay, to draw the diagrams as well in the exams, obviously in theory exams, and also you want to draw it to secure good marks. Fair enough. But you think, okay, I'm not very good in drawing. See, the art of drawing and all, in which is required for you in school time and all that, is there you have to make it as beautiful as possible. But in medical college, it's a professional course, medicine, and here you have to make the things more correct, not more beautiful. So if you want to make, suppose, diagram like this, there's no need to show everything, but just, okay, try to make some illustrations. Okay, this is the your descending colon, then this is the huge cecum over here, right? Then try to make the appendix like this, and make sure the ileum opening over here is simple as that. Then you can show, okay, this is the whole mesentery, this is the whole mesentery, and from here, if you change the color, you can show that, okay, this is the mesoappendix, as simple as that. Now the question comes that, sir, we are learning mesentery, fine enough, fair enough, but why are we learning such a small thing as mesoappendix? It is a very small thing. Why to learn it separately? Just for the sake of completion of course, are we doing it? No. See, appendix, we all know appendicitis and appendicectomy are so important, are so common. Inflammation inside the appendix, and therefore surgically removing the appendix is important. And when you have to remove any organ, you have to obviously cut its blood supply. Clear? To cut its blood supply, you should know where the vessel is. Suppose you opened the abdomen, and after 10 minutes you found out the appendix. Then you are thinking, okay, what to do now? Should I just cut and remove it out? It is not like that. You are doing a surgery on a basically living person. So we have to find out the blood vessel, and that thing, blood vessels and all, nerves and all, they are found in the mesoappendix. So we have to find out the mesoappendix. That is why it is being taught over here, so that later on you should know that where exactly is the mesoappendix, right? So it extends up to the tip of appendix and sometimes may not reach it, but this diagram which you should make contains what? It contains vessels. So you just can't cut the mesoappendix like this, else they will be bleeding. It will contain nerves, lymph nodes, and lymphatics of the appendix. So it will just dissect out slowly through the mesoappendix. And that is why sometimes some students ask that, sir, why so much time we waste in DH dissection hall and all? Simple, because if you want to utilize your time correctly, then these dissections are slow dissections. The more you practice in the first year, the more interest you will get in your career, and it's going to help you immensely in your future professional life as well. That is right. So you have to do a slow dissection on these. Okay, it's not like that you open the abdomen and the appendix is coming out and just showing, okay, I'm the appendix. You have to search for the appendix. Sometimes it's not very easy to find appendix as well, because appendix position varies, as you might have learned in your abdominal gross anatomy as well. So this was mesoappendix. Now similarly, we have mesocolon. Which mesocolon? Colon has 4 parts. How many parts? 4 parts. What are the 4 parts? The 4 parts of colon are, to begin with, is the ascending colon, then you have the transverse colon, then you have descending colon, then you have sigmoid colon. ATDS. The ascending and descending colon over here, they are retroperitoneal. They are retro. On the other hand, the transverse and the sigmoid colon, they are intraperitoneal. Intra means they are completely covered by what? The peritoneum. Therefore, you will never see a ascending mesocolon or descending mesocolon. The term will not come like that. The term will come of transverse mesocolon and sigmoid mesocolon. So transverse mesocolon, the approximate length, if we talk of the colon over here, and transverse mesocolon is roughly around 40 to 50 centimeters. It's not a very small structure, and it is like a U-shaped structure. So it is actually hanging down like this, transverse colon. Transverse colon is hanging down like this, and the transverse mesocolon will come and attach to it like this. And this will be over here, what? This will be over here, the root of transverse mesocolon. We'll just discuss it more. So transverse mesocolon is a fold of peritoneum, suspends transverse colon from the upper part of the post-abdominal wall. It is suspending. Okay, let us see more. Okay, so here they are showing us what? They are showing in this image, this is the small intestine, therefore this is the mesentery over here, MES dot mesentery. This is the transverse colon over here, so we have the transverse mesocolon also. This is a TC over here. And this is the low down as you go, then you have the other structures. Now let us see the root of the transverse mesocolon. Like we did at the discuss the root of mesentery, you have the root of transverse mesocolon as well. What is the root? The root will be more posterior, guys. So it is going to be in front of the retroperitoneal structures. Understand that. Like if you remember, the root of mesentery was in front of duodenum, aorta, IVC, and all those structures. Similarly, the mesocolon root, the transverse mesocolon root, will be in front of the retroperitoneal structures. And obviously, it's going to be in front of vessels. Why? Because what is the mesocolon or mesentery carrying? The nerves vessels. So those vessels, those come from the aorta and IVC, not IVC, that discuss aorta. So therefore, the root has to be in front of aorta or their branches. That is the whole point. Now, transverse colon is both a part of midgut and hindgut that we'll discuss later on. But yes, attachment, let us see of the root. What are the attachments that are shown over here? So anterior surface of the head, anterior border of the body of the pancreas. So it is lying basically in front of the pancreas. Okay, the line of attachment is horizontal with an upward inclination towards the left. So see the point over here is, let me draw a diagram for you guys. Okay, if you start from more posterior aspect, let me try to draw a few structure over here. So let us start with aorta only. So we have this aorta over here. Be with me in the diagram. It is the most posterior structure, the aorta, abdominal aorta, right? Abdominal aorta. Then let us see some branches of it. Say this is the celiac trunk, okay? And say this is the superior mesenteric artery. And as you go low down, we have the inferior mesenteric artery, okay? Talking of the vertebral levels, let me also write over here T12, L1, and around L3. Fair enough. I'm not drawing the IVC just to avoid some confusion. But what I will try to draw now will be the duodenum. So we all know that superior mesenteric artery L1 is a transpyloric plane. So what lies over here? We have the pylorus and we have the duodenum first part. Then we have the second part duodenum. Then we have the third part duodenum and the fourth part duodenum. Am I clear? This is lying in front of aorta. So let us put some shade over here. In the concavity of the duodenum, what structure else? What else we have? We have this pancreas over here. What is this? This is the pancreas. The head of pancreas, the uncinate process, and then you have the body and the tail of pancreas going around like this. It is lying in the front of aorta. Just imagine. This is how the structures are. Okay. Now the superior mesenteric artery, which actually arose from the aorta, is actually behind the duodenum and pancreas. So it will remain behind, and then in front of uncinate process, the superior mesenteric artery will come out. Which artery is this? This is SMA. It is the artery of midgut. Superior mesenteric artery. It was running where in the root of mesentery to supply jejunum and ileum. Now, transverse colon is a huge structure. It is intraperitoneal. It will be running over here only in front of these structures. I'm not drawing over here transverse colon, but we'll draw later. Now, the root of transverse mesocolon is where, now try to understand, it is running in front over here with slight inclination towards the left. This is the root of transverse mesocolon. So as the transverse colon, let me write the transverse colon, let me draw the transverse colon separately over here. This is, imagine the transverse colon. The right 2/3 of the transverse colon is part of midgut. Okay, and the left 1/3 of the transverse colon is a part of hindgut. Getting a point? Therefore, the artery which runs in the mesocolon is the middle colic artery. Which artery? It is a branch of SMA mainly because it is over here. The artery over here is the middle colic artery. So this SMA over here, which is coming out, will also give the middle colic artery that will run through the transverse, through the root of transverse mesocolon, and then it will reach the transverse colon. This will be the root, and it is close proximity to SMA because some part of it is lying in the midgut, and also IMA will come forward and will give up the left colic artery that will go and supply the left part of the transverse colon. I hope you understood 40-50% of what I've told about the transverse colon. As you go ahead, you'll understand more. Focus on where is the root. The root is in front of pancreas. Just I wanted to show you to have some relation of where would be the superior mesenteric artery also. Superior mesenteric artery is also coming through the pancreas, between the head and the uncinate process. Superior mesenteric artery is also coming from posterior to anterior through the pancreas, going where into the root of mesentery, and will give a branch that will go into the root of transverse mesocolon. So point over here is that the superior mesenteric artery which was coming out, it went into where? It went into the root of mesentery first of all to supply jejunum ileum, but it will also give branch like middle colic artery, which will go in, which will go where? Which will go into the transverse M.colon mesocolon. I hope you got in the point. Let's hope. Okay. So line of attachment is horizontal with an upward inclination. Contents is what? Contents, I told you, basically we have this middle colic vessels. Obviously, nerves and lymphatics will be there. I'm not mentioning them again and again. Okay, so this is your transverse mesocolon and transverse mesocolon contents. Now, as I told, we will have a mesocolon of transverse and sigmoid only. So, of sigmoid mesocolon. Sigmoid mesocolon will be present where on the right or left side. If you know the basic anatomy, then you should know that this is the cecum appendix and this is the ascending colon. Then we have the transverse colon going from right to left. Then you have descending colon, and then we have the sigmoid colon. So it is present S, D, T, and A. It is present on the left side. Okay, and if I try to make over here the transverse mesocolon and the sigmoid mesocolon over here. So it will be on the left side. Let's see the points now. Features of the sigmoid mesocolon. It is a triangular fold of peritoneum suspending sigmoid colon from the pelvic wall because it is now going more down. So we mentioned over here the pelvic wall. It is also very important clinically, sigmoid mesocolon. Let me tell you over here. So see, once you are in an emergency or casualty or OT, emergency OT, and there's a laparotomy being done, the abdominal wall is opened. Suppose a gunshot injury comes to you in the abdomen. There are multiple gunshot injuries, and the surgeon residents over there are just in a rush and to do a laparotomy, exploratory laparotomy, okay, to see what organs have been damaged and repair and all. And you, as an intern, reach there, or you're seeing it for the first time. And once you open up the abdominal wall, what you first see is the greater omentum. You reflect it, then you see the small intestine. You reflect it, and then you see all these colons on the sides. Now, the ascending and descending colon, they don't move much because they don't have a mesentery. but this transverse colon and sigmoid colon will be moving. This is how you can easily identify. Okay, so sigmoid mesocolon or sigmoid colon is identified by the sigmoid mesocolon. So a root will be shaped like an inverted V. Do remember that this root over here, it is like this inverted V. Like the transverse mesocolon root was, mesentery root was oblique, remember, mesentery root. Transverse mesocolon root was horizontal, slight incline towards the left. Sigmoid mesocolon root is inverted V shape. This is the root. If you remove all the intestine, this is what you will see in the body. So root is shaped like inverted V. Apex is apex. So when we talk of this, then this point over here is the apex. That is the clinical important, practical important area. So apex over here is where you have the left ureter. Apex will have left ureter at the termination of left common iliac artery. So if you find the sigmoid colon and sigmoid mesocolon, then lift the sigmoid mesocolon and reach the apex. Apex means more posteriorly. And there will be a small tube behind it. If you just rub your hands, you'll feel the tube. That is the ureter. Which ureter on the left side? So left ureter. And obviously left side, so we'll have the aorta bifurcates where at around L4. So we have left common iliac artery as well. And left common iliac artery is a small artery, guys, because it's suddenly divides into external and internal iliac arteries. Let me show you over here. This is the abdominal aorta. Around L4, it divides into common iliac, which suddenly divides into external and internal iliac artery. And here you will have what? The left ureter coming out. Okay, just try to understand. And similarly over here, you will have what? You will have this. Got the point? What is this? This is the mesocolon. Okay, and this will be its root. This will be its root, and this is the apex over here. Apex. This is where you are witnessing the left ureter and the common iliac artery. So left limb. So you can understand the left limb will we have a left external iliac. So this is the left limb. So it does have the E is external iliac artery. And the right limb will have the posterior pelvic wall going downward. Fine. Medially apex to median plane at a level of S3. But this diagram is simple, I guess you'll understand it better. So this is the whole sigmoid colon. Try to draw the sigmoid colon. Colon always, all the four parts of colon, remember to draw the hostrations. Else, obviously, this is the common sense. You don't draw hostrations in small intestine, jejunum, ileum, you don't draw. There it is plain. But in case of colon, you have to draw the hostrations. And along with it, you can see the double lines. What are these double lines over here? What are these? Think. These are the longitudinal muscles known as tinea coli. They are condensed longitudinal muscles. Okay, 3 bands of muscles over here. So then you can easily make, this your transverse, sigmoid mesocolon. At the apex, you can show the ureter and the external iliac artery, basically the common iliac dividing into 2. So suppose you have to reach the left ureter. Ureter itself being a retroperitoneal, how you are going to reach? Simply, if you are looking into the abdomen, search for the sigmoid colon, then sigmoid mesocolon, and then you can easily go to the apex of sigmoid mesocolon, and around it you will find your left ureter. This is which side ureter? This is the ureter of the left side. Understood? You have to avoid any scalpel use over here, because if the ureter is cut, then there will be leakage of urine. Understand that? Okay. That was sigmoid mesocolon. Contents will be what? Again, you will have the sigmoid vessels. You can say the sigmoid arteries. Now, these will be branches of which artery? If there are 3 options: celiac trunk, superior mesenteric, and inferior mesenteric artery. Now, the entire descending colon, sigmoid, rectum, and all is a part of hindgut. Therefore, the sigmoid arteries over here, they are branches of inferior mesenteric artery, because it's an artery of hindgut. Okay, you have superior rectal vessels also part of inferior mesenteric artery. So this was your mesocolons. Then you can see a short note on the epiploic foramen as well. Epiploic foramen you discussed. What was that? If you remember, then it was joining the lesser sac to the greater sac, also known as foramen of Winslow. So epiploic foramen or omental foramen or foramen of Winslow definition, it is an opening into the lesser sac. Again, I advise you go to the previous lecture. There we discussed the epiploic foramen in detail, including the boundaries we discussed. Let us revise it again. So it is a vertical slit-like opening which the lesser sac communicates with the greater sac. Very good. It is foramen behind the right marginal lesser omentum at the level of T2, which I already told you initially previously, right? So in the diagram, what they made is the stomach over here. and the duodenum over here. And this is your LO is lesser omentum. Omentum is a mesentery. And this is going from lesser curvature of stomach and going, and this is the right border having this portal tride structures, P dot tride structures. And this is the site for your epiploic foramen, as is written already over here. This is the site of epiploic foramen. Okay. Behind you will have the IVC and the T12 vertebrae over here. See, sometimes you see this as a in diagram, guys. What is this over here? Try to understand. This is very helpful. A is more anterior. P is more, so obviously vertebrae is more posterior and stomach is more intraperitoneal, so it is more anterior. So above you have the liver, so S is superior, I is inferior. Inferior, here the first part duodenum. So all these are boundaries if you remember, right? So boundaries of epiploic foramen are very important. Second, what is the clinical use of it? Let me also tell you the clinical use of it. Suppose, understand the clinical use first of all. Then you will have some interest why we are studying in so much detail. The clinical interest of this is above what we have the liver over here. What is attached to the liver? We have the gallbladder also over here. Surgeries are commonly done at gallbladder, we all know. Cholecystectomy or into the bile duct surgeries are done. Liver surgeries are so much done. Suppose during doing a surgery on the liver or gallbladder, there occurs what? There occurs a bleeding. Okay, and you are not able to identify the bleeder, that from where the bleeding is coming out. You are not able to identify some. And this, so all this red blood, pool of blood, which is on the OT table. What are you going to do? You know, you have the epiploic foramen. What is in portal triad? Portal triad has the two structures which are the blood vessels of the liver. What is that? Portal vein and hepatic artery. So if you can immerse your finger, because I told you that epiploic foramen is not a small foramen, finger can easily pass through it. Your index finger can easily pass through it. So you can insert your index finger behind or through the epiploic foramen, going behind the lesser omentum, and your thumb in front of it, like this, right? And you compress this right margin. Once you compress this, you are compressing the both of these structures. It will decrease the blood which is going to the liver, and therefore bleeding will slightly decrease. Or you can even put a ligature, and then you can identify the bleeder and correct it. This maneuver is known as Pringle's maneuver. This maneuver is known as Pringle's maneuver, frequently asked, and you can also write it in the form of your clinical anatomy. Okay, Pringle's maneuver, remember it. Okay, so lesser, this is the epiploic foramen. Boundaries anterior, what we have this right margin. So we have anterior, basically we are going to have this portal triad. Posterior, we have T12 vertebrae, IVC, and yes, right atrium will also be there. Superiorly, we have the liver caudate process. Inferiorly, we have the D1, first part of duodenum, and some part of the hepatic artery as well. Okay, yeah, epiploic foramen is an important topic, guys. Why important? Because sometimes you might think, okay, I have to enter the lesser sac, because epiploic foramen is what? It is connecting the lesser sac, which is present where? It is present behind the stomach. Lesser sac is a cavity, peritoneal cavity present behind the stomach. So this epiploic foramen is connecting the lesser sac to what? To the greater sac, the general peritoneal cavity, the whole. So suppose there is some fluid accumulation in the lesser sac. Suppose there is some blood accumulation or blood or fluid accumulation, and you have to reach the lesser sac. Then what may come to your mind? Okay, then I can enter through epiploic foramen. I will just extend the opening and I will enter it. But the point over here is why we are learning the boundaries, because all these boundaries, anteriorly, posterior, superior, or inferior, are having those structures which cannot be cut. So you can't extend the epiploic foramen much. You can enter into the lesser sac easily through the epiploic foramen, because this is the epiploic foramen is a small space, right? And then what will happen? You have the huge lesser sac we'll discuss later on with all those recesses. So you can't extend it more. Why? Because you have the important boundaries around. You can't cut liver, you can't cut the vessels, you can't cut the duodenum, you can't cut the IVC. That is the point, right? We should know the boundaries. Yes, now comes the part where you have to learn about the lesser sac. As I told, that lesser sac is a peritoneal cavity present where? Behind the stomach. And as I was telling you, it is a huge space having all those recesses. Recesses are extensions, as you'll see further on, right? So let us see the lesser sac. Don't ever forget that the other name of lesser sac is omental bursa. Omental bursa. So it's a large recess of peritoneal cavity behind the stomach, lesser omentum, and the caudate lobe of liver. Right border communicates with greater sac through the apical foramen. Basic, this is what you have to write in the beginning. Then the boundaries of lesser sac understand. Okay, let me show you the diagram again of lesser sac as you go. This is the TS, transverse section. You can see the anterior, the posterior, the right, and the left side. Okay, this is the stomach over here. And this over here, if I put a highlighter, this is all what is all lesser sac. This is all lesser sac. And if I try to show you the epiploic foramen, this will be the site of epiploic foramen. Epiploic or foramen of WINS LOW means low. And this is your greater sac in front of stomach. Understand? Okay, so there's a TS, and if you want to look at a horizontal view, then see over here. This is all the lesser sac. It might be looking very strange over here, but remember, the duodenum is being shown to you over here. This is the duodenum, D for duodenum. Let's change the color. This is the P for pancreas, D for duodenum. The stomach has been removed. So the lesser sac over here is present behind the stomach, and you can see that it is having a lot of recesses, like superior recess, splenic recess, or inferior recess. All those recesses are there. Okay, just I'm showing the diagram before going to the main topic, because see, let me tell you, there are ways to learn any subject. For example, anatomy over here. You know basic idea what is lesser sac. It is present in the cavity behind the stomach. Now, suppose you start to look only at the theory. Bond is lesser sac is this and this and this. Okay, recesses are this and this. You will be confused, and your mind will tire very easily. Now, suppose you look at the diagrams for a few seconds. Okay, this is what is happening. Okay, okay, okay. Then you will see the next. Okay, this is what is happening. Interesting. Then you go to the theory. Then your mind will work in a different way, in a very easier way, because your mind is already primed that okay, lesser sac is not a simple box of cavity like this. Okay, this is lesser sac. It is something, because this is what we are learning. What nature has made. So it is not going to be a simple square or simple circle. What we draw on our uh, sheet of paper, right? This is main. This is something that is natural. Let's now come to the topic. So boundaries of lesser sac. Anterior, what you will have anterior as see. The lesser sac is behind the stomach and mainly liver, as you learned the first line over here, behind the stomach and liver. So anterior boundary will be having what? Will be having the stomach and mainly the liver. Simple as that. And between the stomach liver, we have the lesser omentum. Okay. And what is this? Saying the second layer of greater omentum. This is interesting. This is interesting. How? Let me show you how in a form diagram. Now, suppose this red color over here is the stomach. What is this? This is the ST dot stomach. And I am making a sagittal section having anterior side over here, posterior side over here. Just a minute. Sagittal section of the body, and you are looking at the stomach. I hope it is clear. Looking at the stomach. Which side are we looking at? We are looking at a left view. This is the left view. The diagram which I am making is a left view. Just be with me. Therefore, this will be the greater curvature. It is more on the left side because we are looking at left view. From here, what will come is will be the first layer of greater omentum, and along with it, you will have the second layer of greater omentum. Let me write over here layer number 1 and layer number 2. Am I clear? So this layer number 1 and 2, what will happen to them? This layer 1 will go back like this. As which layer? This will be layer number 4. And what about layer number 3? Layer number 3 also we are making. This will be the layer number 3. This is going to which layer? This is going to be the layer number 3. We discussed previous session that greater omentum has 4 layers. 1, 2, 3, 4. And then what will happen is, you know that this will go like this, 3 and 4 will go like this. They will cover which structure? If I draw a structure over here, then they are covering which structure? This structure or this part of the gut will be the transverse colon, T dot colon. Okay. And then these third and fourth layers are going to cover the transverse colon, third like this and fourth like this. And then they are going to go back as a transverse mesocolon. So this will become what? This is going to become the transverse mesocolon. Okay, sir. Then so why are you discussing this? All of this 1, 2, 3, 4 layers. The reason I am discussing all of this is, what is this space behind the stomach? This space is what? This space is the L dot sac. And therefore, if you understand this more, then this is going down like this in between the layers of greater omentum. So you see over here, then what you realize is that lesser sac is between which two layers, second and third layer. So you see over here, this is the second layer over here, layer number 2. Okay, let me write this layer number 2 over here and layer number 3. So lesser sac is between layer number 2 and 3 in the lower part of the lesser sac, not above. In the lower part of lesser sac, it is between layer number 2 and 3. Therefore, if you look at the boundaries over here, what are they saying? Anteriorly lies the second layer of greater momentum. Think about it. Anteriorly is what? It's the second layer. Second layer was which one? Second layer was very simple. This was our second layer. This is the layer number 2. Okay. Posteriorly is what? Posterior is the third layer of greater momentum. See. So second layer actually continues into third layer. So in case of greater momentum, remember the first layer continues as the fourth layer, the second layer continues as the third layer, and between these two lies the lesser sac, not the entire lesser sac, basically some lower part of the lesser sac. Because what we discussed previous session also is that majority of the greater momentum will actually all these layers are going to fuse, but some part does do remain. It is nature. We are discussing the something which nature has made. Therefore, some amount of lesser sac will be between second and third layer. Second layer anteriorly, third layer posterior. Okay, so anterior boundaries we have seen. Posterior, what will be lying? Posterior, we have the third layer of the greater momentum, then peritoneum covering the transverse colon anteriorly. Upper layer of transverse mesocolon, right? They are all behind the lesser sac. You can understand. Peritoneum covering the anterior surface of body of pancreas. Why? Because you have the attachment of the transverse mesocolon. All these structures they are lying posterior. Just imagine over here that what will be lying behind. If I try to make with the yellow color all this area. This all is what? This all is posterior boundary of lesser sac. This all is posterior boundary of lesser sac. Okay. Upper lower also, let us see that. Upper lies obviously the liver will lie upper. Lower we have the right margin of the greater momentum, reflection of peritoneum from neck of pancreas. And you have the right side, you have the pubic foramen, obviously. On the left side, you have the left margin of greater momentum. I can just read through it. But remember, the important clinical importance over here are the right side, you have the epiploic foramen. So if you are entering through the epiploic foramen, you are entering through the right margin of the lesser sac, not momentum sac, lesser sac. Okay, this diagram I already told you it's a TS, transverse section. And this highlighted part was the lesser sac. This highlighted part was the lesser sac. This was the epiploic foramen. So it is present where epiploic foramen present where? It is on the right side. It is on the right margin. Okay. Subdivisions of lesser sac. So you have some recesses over here, but before that, let us see a couple of vessels. Common hepatic artery raises a sickle-shaped fold of peritoneum from the posterior wall known as the right gastropancreatic fold, and left gastric artery makes it. So these see what happens is inside the peritoneal cavities, you have these vessels obviously running in the peritoneal fold. They will raise some fold. Simple as that. Just go through them. Their names for once. Don't worry too much. You have a gastropancreatic fold, right and left gastropancreatic fold. Just remember this. That is in the two gastropancreatic folds divide the lesser sac into superior inferior recess. Okay, so you have the arteries going on, and due to which they divided the lesser sac into superior and inferior recess. As simple as that. Questions might come that which artery is forming which gastropancreatic fold. Remember that can come as an MCQ in your exams. It will be a tough MCQ, but don't worry. That also might come. So superior recess, inferior recess, splenic recess, these three recesses over here. And also look at the diagram. Let me highlight these recesses over here. Superior recess. Okay, you can see very well. Then look at the inferior recess. This diagram, I hope you can understand. We have removed the stomach. Okay, and this blue sea over here, this blue island over here, or not island, blue lake over here. This small lake over here, this lake is the lesser sac. And the lake has a superior recess. Okay, this lake has a recess going on the left side to the spleen known as splenic recess, and has some recess going inferiorly known as the inferior recess. It's a lake. Okay, simple remember it as a lake, right? And you can write one line over here. Superior recess lies behind the lesser momentum and liver. Behind the lesser momentum is also known as the vestibule of lesser sac. Inferior recess lies behind the stomach. Spleen recess lies going towards the spleen, so between the ligaments, of course. Okay. Now let us look at one more spaces, which are known as subphrenic spaces. Okay, a couple are left now, not much, but see, basically all of these are extensions. What you are reading till now are basically extensions. So subphrenic, phrenic means what? Phrenic, you have a phrenic nerve. phrenic nerve, which has a root value of C3, C4, C5, supplies with structure, supplies diaphragm. So when we use the word phrenic, it actually means diaphragm. So the recesses below diaphragm. As I've told you earlier also, the diaphragm is not a horizontal sheet of muscle. It's a combination of muscle which is going out like this. If I make from end, suppose I make it from anterior to posterior, let be with me, and anterior to posterior over here. If I'm trying to make diaphragm, look over here. Diaphragm will be actually going like this, anterior to posterior. It's going like this. Okay. So we have few recesses which are below the diaphragm, different areas. So they are known as subphrenic spaces. Supracholic compartment, subphrenic spaces. Supracholic, I hope you remember. Anatomy in abdominal anatomy, remember, where we had the transverse mesocolon. Remember, transverse mesocolon trach where in front of pancreas. Above it is supracholic and below it is infracholic. For a basic understanding, this much is done. So subphrenic spaces are present just below the diaphragm in relation to the liver. Because just below diaphragm, we know we have majorly we have the liver. So it is around the liver. Classification, we have 4 intraperitoneal spaces. They are completely surrounded by peritoneum and 2 extraperitoneal spaces. So revise, you can write it. They are theoretically more important. Surgically also they are important, but not that much. But theoretically they are important. Okay, so 4 intraperitoneal and 2 extraperitoneal spaces. Remember what are the names? Left anterior, left posterior, right anterior, right posterior. Also, it's a huge structure, no, diaphragm. So you have right and left side. Okay, right side liver, left side of liver. So right anterior, left anterior, right posterior, left posterior. 2 extraperitoneal are right and the left extraperitoneal spaces. Understand the diagram. Don't worry. So here we have the spaces over here showing you through it, right? Let me use a highlighter. So right subphrenic space, left subphrenic space. Around the liver only. Right and left side, anterior, posterior, in front anterior, behind posterior. Simple as that. Subhepatic space, so it is going below the liver. And you can see this all over here. If I may use a pen over here, right? This all over here will be supra intracholic. It's going to be infracholic because they are below the TC transverse colon. And what is this structure over here? Can you identify this structure? This obliquely going structure going from DJ flexure to say the right sacroiliac joint. This is the root of mesentery. So this all being infracholic. Okay, so this was, imagine, infracholic, and then you have this root of mesentery going down, which actually divides the infracholic into right and left infracholic compartment. You can see right and left infracholic spaces. Okay, I'm telling you over here only in this diagram. So 4 intraperitoneal were right and left anterior posterior. So you can imagine anterior posterior, subphrenic spaces, and 2 extraperitoneal also will see. But I'm telling you, this is all SC, supracholic, and this is your infracholic. Infracholic is divided by this root of mesentery. This is oblique, what I made this. I made the root of mesentery into a right and left infracholic compartment. And then you are seeing over here, if I change the color to red, can you see the A dot colon ascending colon and D dot colon descending colon? Lateral to both of these, what we have over here, we have the paracholic cutter. They are known as what? Paracholic cutters. Can you see the names over here? Right and left paracholic cutter. This is how the spaces are made. And can you see the arrows over here, guys? Arrows over here. These arrows are showing you how the peritoneal fluid moves around, how the lymphatics moves around, how the lymph flows through these spaces. So if suppose a question comes up to you guys, asking you, let me ask you, okay, which space is this? This is left infracholic. This is right infracholic. These are the paracholic cutters. And these are your intraperitoneal spaces, subphrenic spaces. This is lesser sac over here. Okay. This is quite interesting. Go through diagrams, you'll understand it. So you have 4 intra and 2 extraperitoneal spaces. Okay. And midline extraperitoneal, as there's also midline extraperitoneal spaces. It's just a name given to the bare area of liver. Fair enough. So left anterior space. So now we are discussing what, see, what are these four? These are IP, intraperitoneal spaces. Left anterior, left posterior, right anterior, right posterior. Okay, IP spaces. And these are EP, extraperitoneal spaces, left and right, and midline extraperitoneal spaces. So 4 plus 3, we can add midline also bare area. Total comes out to be 7. Left anterior. Okay, left side anterior. So left side of liver and in front. So it will be lying between the left lobe of liver and diaphragm. Below you have the stomach, left side you have the spleen. You can understand. Left posterior is known as left subhepatic space. The right anterior is the right subphrenic space. It is lying between the liver only spaces. But do remember over here the right posterior space. This is important. Or right subhepatic space. Why is this important? The thing over here is that this is important because it is also given a name, and that is your Morrison pouch. Why is this important? Let me tell you the applied aspect of it before going into the diagrams. It will come as a point later on. The right posterior is between the liver and the structure lying behind, that is the kidney. And it is the most dependent. Suppose the patient is admitted due to say any acute abdomen, any pain, acute pain in abdomen, or abdominal peritonitis, anything. Patient is lying on the bed. When the patient lies on the bed and there occurs a buildup of fluid accumulation in the abdominal cavity. The patient is lying on the bed, where will the fluid go? Fluid will go to the, with the help of gravity, the most posterior space in lying down. And that most posterior space in lying down is your Morrison pouch. So it is the most dependent position in supine. Most dependent space in supine position. Dependent means gravity-wise most inferior. Most dependent space in supine position is Morrison pouch. Okay, then you have the left extraperitoneal, right extraperitoneal. So obviously extraperitoneal, so you have the around the kidneys. And midline is the bare area of liver. Okay. Now here comes the Morrison pouch, as I told you. It's important, right? It is between the liver and the right kidney. So it is more on the right side, right posterior space. Anteriorly, what it will have? Anteriorly, it will have the liver, and behind posterior, it will have mainly the kidney and the radial structures. Simple as that. Why is this important, guys? Because I don't want names. If you go to the casualty, suppose there is a patient comes with an acute abdomen or abdominal trauma or something like that, or any trauma case, you have to do a E-fast procedure. What is E-fast? Basically, it's an ultrasound procedure done immediately to see any fluid or blood accumulation inside the peritoneal cavity, inside the abdominal cavity. While doing ultrasound in the stomach, the radiologist obviously knows the anatomy, and radiologist looks for the fluid collection in the Morrison pouch. Because patient is lying down, suppose there is a buildup of fluid, the fluid will not suddenly be multiple liters and to cover the entire abdomen. No, it will start from somewhere with a minimal amount. Okay, so Morrison pouch is important. Similarly, therefore, what we see in an X-ray, chest X-ray, is the costodiaphragmatic recesses. Because if there's any minimal fluid in the pleural spaces, it will first build up in the costodiaphragmatic recesses. You have to get to the point, right? So anterior we have the liver, posterior we have this all the structures like kidney, duodenum, colon, all that. Superiorly we have this, what is coronary ligament? It's nothing but the ligament of the liver on. Inferiorly it opens up into general peritoneal cavity. So it is not a blind space, it is opening up. Moment the patient sits, then obviously the fluid from there will trickle down slowly into the general peritoneal cavity. Left side, as you can see, it opens into the congenital bursa. Let me show you in the immediate in that previous diagram only. Where would we see in the transfer section? I will show you. Okay, here it is. So in this diagram, we can see the liver over here. Okay, and we can see the right kidney over here. I hope all of you can see. So where will be the Morrison pouch? Morrison pouch is this yellow colored structure. This is the Morrison pouch. And therefore, in the question, they were saying that on the left side, where it is opening, on the left side, you can see again this whole ectopic foramen opens up into the lesser sac, and the anterior or below it will open into the greater sac. So the left side opening into the lesser sac. This is what was written over here. Okay. Left side communicate with the omental bursa. What is omental bursa? That is the lesser sac. I hope you got the point, right? So above you have the liver, below it is opening into the greater sac. On the left side, as you go more, suppose the patient lies in the left lateral position, like lies. Okay, left lateral position is lying. Obviously, from Morrison pouch, the fluid will accumulate into the lesser side, and right side limited by the diaphragm. Okay, some diagrams over here that you can easily see. So spaces being shown over here. Let me add one more name. So what was this Morrison pouch? It was right posterior. Let us write over here. Right posterior is the Morrison pouch. Okay. Similarly, another important is left posterior, which I didn't told you at that time, but left posterior is what? It is on the left side of the liver, or the left side of the below diaphragm, more posteriorly. So liver and stomach are connected by the lesser mentum. What lies behind the stomach and the liver on the left side? Lesser side. So what we learn in detail of lesser side, orthomental bursa is also the left posterior intraperitoneal space. Can you see this over here? Okay, this is your whole lesser side. This is the whole lesser side over here, behind the stomach, behind the stomach. And here, if I may say it again, these are the one layer, two layer, and this is layer number 3 and layer number 4 of greater omentum. And they are then layer number 3 and 4 are covering the transverse colon. Then this forms the transverse M dot colon, which goes in front. This is the root of missing. This is the root of transverse colon over here. What is this black color over here? Or let me put some red color. This is nothing but the root of TMC, transverse mesocolon. I hope you're getting the point, right? Okay, fair enough. So this was it, and as we go forward, let the page open up. Okay, yeah, infracolic compartments. As already told you that below the colon we have the infracolic divided by the mesentery into right and left infracolic. But the right infracolic compartment lies between the ascending colon and the mesentery below the transverse colon. No worries, you should know, have a basic idea. This is the cecum appendix. Okay, ascending colon, transverse colon, descending colon. Okay, color change, root of mesentery. Okay, and therefore this is the right infracolic compartment. So it is between ascending colon over here. Let us label it ascending colon and mesentery. This is the M for mesentery, and below the transverse colon or transverse mesocolon, to be more precise. Simple as it. Left one lies between descending colon. So this is the descending colon and this is the mesentery. So this is the left infracolic space. Simple as that. Here again, a right and left supra-infracolic. And here we can take this opportunity to draw mesentery over here, showing the right and left infracolic compartment. Paracolic cutter also, remember, this is quite important because the fluids from the above or below can easily percolate and reach the peritoneal cavity easily through the paracolic gutters. Okay. A second. Okay. So fluid from here, right and left paracolic gutters can easily come from above below or below above. So they are also important. Paracolic gutters, right lateral paracolic gutter, have some idea of it. Opens freely into the peritoneal pouch at the upper end. You can see upper, what will lie upper over here? You have the right kidney behind. Yes or no? So this is the area of the Morrison pouch. So it is Morrison pouch is most dependent while the person is lying supine. The moment person starts to sit up or stand and walk, so obviously the fluid from here will trickle down into the pelvic space. The right lateral paracolic gutter opens freely into the abdominal pouch at its upper end, infected by downward spread of infection from abdominal pouch and from the lower side. So yeah, I hope you got the point what they're discussing. Left paracolic gutter opens freely into the pelvis at the lower end. Above separated from this is the important part, guys, for your PG exams. That the left paracolic gutter is above, it is separated from the spleen by which ligament? By phrenicocholic ligament. This is the point. So unlike the right side, where we saw that, okay, we can easily go from here to here. On the left side, what happens is that here you have a phrenico means the diaphragm and colon is this sigmoid flexor colon. We have a ligament over here that is known as phrenicocholic ligament. So this somehow it prevents the free flow of fluid on the left side compared to the right side. Like it was freely flowing from Morrison to the pelvic space on the right side, it is not as free on the left side. Okay, then rectouterine pouch. Finally, you can see, understand that also obviously found mainly, or not mainly, but only in females, because it's between the rectum and the uterus. Uterus male is only in females, so rectouterine pouch. It is the most dependent space in females in sitting or standing position. So most dependent when body is in upright. Remember in pelvis, see what happens is anterior to posterior, there are three major structures. What are those? Anterior, you have the urinary bladder. Posterior, you have the rectum or the anal canal. And if it is a female, in between, you have the uterus as well. Simple as that. So what normally we have is, we have a peritoneum that is going around like this. And therefore, this forms the most dependent space. This is the recto-uterine pouch, a pouch of Douglas. I just making like this for you to understand. Diagrams are better. So boundaries anterior. Okay, again, look in the diagram first. Forget about the boundaries. Look in the diagram. Understand the body from here, and then you can go further. So this is the anterior side. That is the posterior side. Why posterior? Can you see the vertebrae over here? S3 is sacrum. Anterior, as I told, that most anteriorly, if the highlighter, I am leaving the organs, you have the urinary bladder. Over the urinary bladder is the uterus that is sitting, and this is the rectum that is on the posterior side. And with this yellow highlighter, let me show you what is this. This is your recto-uterine pouch or the pouch of Douglas. It is very, very important clinically, right? It is very, very important clinically. DOUGLS. Douglas. Douglas. Okay, so pouch of Douglas. Now see, when the fluid, suppose any fluid, pus, any collection starts to collect over here, suppose I change the color to somewhat bit bright. Okay, suppose there's some fluid or tinge of blood in the pouch of Douglas. Pouch of Douglas means it is just a continuation of what all the general peritoneal cavity going down. So the moment a lady sits or stands up, any fluid collection will accumulate down into this recto-uterine pouch. I hope it is clear. Now, how to drain it? Because if there's any collection of fluid, you have to drain it. Drain it may look very complicated. So how to reach it? Simple way is, if you are looking over here with a organ vagina opening outside into the perineum, what can be easily done is, if you insert a needle over here. Let me change to say yellow color over here, but that might be seen. We insert a needle through the vagina. Okay, needle is going, and through this posterior fornix, needle can straight away enter into the recto-uterine pouch. Straight away. Without doing any surgery, and all, you can straight away enter into the recto-uterine pouch. Okay. That is recto-uterine pouch for you guys. And there you can see the boundaries. Anterior, the uterus and the posterior fornix of vagina. Behind you, the rectum. Inferior, you have the recto-vaginal fold of peritoneum. Right. Easily. Peritoneal fossa or peritoneal recesses. Okay, right. A short one that also can come. So peritoneal fossa over here. What is this? Small packets of peritoneal cavity. Last topic over here. Enclosed by a small and constant fold. So see, peritoneum is not a simple sheet of paper. Paper is folded here and there. So as the paper you fold here and there, they develop some air gaps or not. If you take a sheet of paper, okay, sheet of paper, just make a ball of it. When you make a ball of it, you have multiple air pockets inside the folding of paper. Simple as that. So small pockets of peritoneal cavity enclosed by small folds of peritoneum. Once you make a ball from a sheet of paper, and there are multiple air pockets inside. This is your peritoneal recess. So that is peritoneal cavity is inside the fold of peritoneum, as simple as that. Commonly occur as the transition zones between absorbed and unabsorbed parts of mesentery. Sometimes persist to form a potential site. Now that is the applied aspect. Sometimes it can form a site of internal hernia and their strangulation. That is something which, as a doctor, you have to be more cautious about. Lassus, like we have seen, is the largest recess present. Now, duodenal fossa recess. Now, see what happens is, why is there too much of folding occurring over here? Duodenum has a first part, then a second part, a third part, and a fourth. This whole duodenum is retroperitoneal. Suddenly, this duodenum becomes jejunum. Now, jejunum is what? It is intraperitoneal jejunum. So, jejunum will keep on moving as well. So, this junction becomes important. So, this is a pipe only. One part of the pipe is fixed, and one part of the pipe or one end of the pipe is moving. So obviously their junction will develop some recesses that are known as all of these recesses: superior duodenal recess, inferior paraduodenal, retro. Right, see, but the lines, they are not present all the time, but obviously they're present somewhat. The questions that used to come previously as a single line multiple choice question was, what is the vessel present in the paraduodenal recess? Paraduodenal recess is present in about 20% of the subjects. This is the question that used to come a lot. Inferior mesenteric vein lies in the free edge. Therefore, I'm just putting a star mark over here. This was one of the famous questions. Okay. So you can see in the diagram also, you can see this duodenum over here, and you can see the jejunum over here. And at this point, you have superior recesses, inferior recesses, and folds and all that, right? Okay. Finally, we have this peritoneal parietal fossa Voltaire also, only about 1%. And finally, you have also in the cecum. Why cecum? See, again, you have this iliocecal junction. Okay, so cecal is what if you remember, then you have that ileum and cecum with appendix, and this is all cecum. So again, this ileum over here is intraperitoneal, and this is fixed structure cecum. So again, you have the superior, inferior, and retrocecal recesses over here, where the appendix also might lie here and there. This is your recesses. Simple, see the diagram. And recesses are folds. Folds, remember, I gave you an example: a sheet of paper, make a ball of it, pockets over there. Intersigmoid recess, also you can just go through it once, right? So these are diagrams over here. And then you have some of the MCQs. This was the whole theory part, guys. Whole theory part. So just go through it. I hope you guys enjoyed it. Go through it, revise. What we discussed today is just the extension of the peritoneum or the concept. So this is the actually combination of two lectures, previous and this. Okay, though that's all from my side. I hope you enjoyed it today. Like always, and this is what the plans that we have seen. And also, yeah. So that's all from my side. Bye-bye and good night. And follow us on the social media handles as well. Thank you. See you.